Good morning, everybody. Today we are speaking about paralytic squint or incomitant squint, and we want you to be safe and stay at home, and we will deliver you all the lectures. So keep safe and stay at home. And I like to thank RM Solution because they are helping us to keep you safe and to keep you staying at home. Thank you, RM. Now we have to know the extraocular muscles. The extraocular muscles are 6, we know before in the anatomy. There are 4 recti and 2 obliques. The 4 recti muscles are inserted in front of the equators, and the 2 obliques are inserted behind the equator. All of the extraocular muscles are supplied by the oculomotor nerve except 2 muscles. The lateral rectus supplied by the 6th cranial nerve or abducens nerve, and the superior oblique muscle which is supplied by the 4th cranial nerve or the trochlear nerve. Here are the muscles, we can see them also. The superior rectus above the globe, number 1. Below the globe, inferior rectus. Medial rectus in the medial side, lateral rectus in the lateral side. Superior oblique here between the superior rectus and medial rectus, going from the apex of the orbit to the trochlea and reflected back to be inserted in the posterolateral quadrant of the globe. And number 6 here is the inferior oblique, the only muscle not originating from the apex of the orbit. It arises from the floor of the orbit. All the muscles are originating from the apex of the orbit except the inferior oblique, which arises from the floor of the orbit, from the rough impression just lateral to the opening of the nasolacrimal bony canal. Here again, there are 6 extraocular muscles, 4 recti, medial rectus, lateral rectus, superior and inferior rectus. 2 obliques, superior oblique and inferior oblique. The recti are inserted in front of the equator. The obliques are inserted behind the equator. All of the muscles are originating from the apex of the orbit except the inferior oblique. Okay? Now the nerve supply. The lateral rectus is supplied by the abducens nerve or the 6th cranial nerve. Superior oblique by the trochlear nerve or the 4th cranial nerve. All other muscles are supplied by the oculomotor nerve. Lesions that lead to paralytic squint are always of the level of the lower motor neuron, that is from the nuclei and to the nerve and to the muscle. From the nuclei means the nucleus of the 3rd, 4th or 6th cranial nerve. The 3rd and 4th nuclei are in the midbrain at the level of the superior colliculus for the oculomotor, at the level of the inferior colliculus for the trochlear nerve, and then the 6th is in the pons. Okay? So lesion in this area affecting the nuclei can cause the paralytic squint, either diabetes, tumors, arteriosclerosis. In the nerve itself, 3rd, 4th or 6th, as tumors, aneurysm, trauma, meningitis, something inflammatory or traumatic or tumor type. In the muscle itself, as something in the orbit. The signs and symptoms of paralytic squint include, first of all, limitation of movement in the direction of action of the paralyzed muscle. This is not present in concomitant squint. Ocular deviation. The deviation in paralytic squint is variable. Variable deviation, the angle of deviation which is variable, is maximum when looking in the direction of action of the paralyzed muscle. The angle of secondary deviation is bigger than the angle of primary deviation. And here I know you want to ask what is the primary and what is the secondary deviation, and I will tell you in few seconds. Also, among the signs and symptoms, there is diplopia. The diplopia means double vision, one image from the right eye and another image from the left eye. This is contrary to another type of diplopia, which is uniocular diplopia, which is not our subject here. The binocular diplopia is one occurring in paralytic squint. There is one true image and one false image. The false image is always in the direction of action of the paralyzed muscle. So, there are many types of diplopia. In lateral rectus paralysis, there is homonymous or uncrossed diplopia. In medial rectus paralysis, heteronymous or cross diplopia. In superior oblique paralysis, there is vertical diplopia. Here, I know you want to ask, if we put in mind, for example, here, right lateral rectus paralysis. The right lateral rectus, what is the action of the right lateral rectus? Is to look to the right. To look to the right, so the false image will be to the right. So, the right eye, which is having the paralysis, is having the false image toward its side. This is homonymous diplopia, means the false image is in front of the deviated eye and the true image is in front of the normal eye. So this is uncrossed diplopia, and we will see all of them in few minutes, so don't be worried. Also, there is vertigo, nausea and vomiting due to diplopia all the time. There is false orientation in space in the direction of action of the paralyzed muscle. Why? Because extra impulses are going to the paralyzed muscle to fixate to the object, and at the same time extra impulses are going to the hand to catch or to pick this object which is present in the direction of action of the paralyzed muscle. So there is a false orientation in this direction. But if this patient is trying to pick an object in the opposite direction, or in the direction of the normal eye and normal muscles, there will be normal orientation. So the false orientation in space in the direction of action of the paralyzed muscle. Also, an important characteristic of paralytic squint, which is not present in comitant squint, is abnormal head posture in the form of head tilt, face turn, chin elevation or depression. And we will see all of them just now in the different types of paralytic squint. Now to explain to you the angle of secondary deviation and angle of primary deviation. The angle of primary deviation is the angle of deviation of the squinting eye when the normal eye is fixing. Here is the angle of secondary deviation. Note the amount of deviation in this eye. Now, the angle of secondary deviation. What is the angle of secondary deviation? It is the angle of deviation or angle of squint of the normal eye when the patient is fixing with the squinting eye, or even how he can fix with this eye. Either we can put here a semi-translucent cover, or if we ask him to fixate and he can be cooperative and fixate with this eye. So we can put here a semi-translucent cover so that the patient will not see with this eye, and we can see the deviation across the semi-translucent cover. Note here that the angle of secondary deviation here is bigger than the angle of primary deviation. Why? Because of the impulses and the Herring law of equal innervation. When the patient want to fixate with this paralytic eye, with the paralytic squint, there is increased innervation to the paralytic muscle to fixate, and this is accompanied by increased innervation to the yoke muscle of the other eye, that is the major rectus of the other eye, which is normal, and here there will be more deviation because the excessive impulse here make a little movement, while the excessive impulse here will lead to excessive movement and to a bigger angle of secondary deviation. So the angle of secondary deviation here is bigger than the primary deviation of the squinting eye, and this is according to Herring law of equal innervation. Now, abducens nerve palsy, or 6 cranial nerve palsy, or lateral rectus paralysis, all are the same. There is limitation of movement in the direction of action of the lateral rectus. There is limited abduction. The eye by time will be convergent due to unopposed action of the major rectus, which is normal. The deviation is variable, maximum when looking in the direction of action of the lateral rectus, that is when looking out. Diplopia is homonymous or uncrossed, and also face turn in the direction of action of the lateral rectus, that is toward the affected side. I want to tell you here a rule that the head goes where the eye should go. Paralysis of the right lateral rectus, the right lateral rectus is making the eye turn to the right, so the head will be turned, or the face will be turned to the right. Face turn in the direction of action of the affected muscle. Here is the normal object here. Its image is falling on the fovea of both eyes. But if the lateral rectus is paralyzed, this eye will be turned in, and the image, instead of falling on the fovea, will fall on an extrafoveal point. This extrafoveal point is on the nasal half of the retina, nasal to the normal fovea. Any image of an object when falling on the nasal part of the retina will be projected in space as if coming from the opposite side, and in this case this image will be projected as if coming from the right side. So the lateral rectus paralysis will lead to uncrossed diplopia, means that the normal object will fall on the normal eye, and the false image here on the in front of the deviated eye. Normal and normal, the false in front of the deviated eye, no crossing, uncrossed diplopia, and called homonymous diplopia. If we forget, we always remember that the false image is always present in the direction of action of the paralyzed muscle. The direction of action of the lateral rectus, which is the paralyzed muscle, is looking to the right. So the false image will be to the right. And I will explain also the rest one by one. Left lateral rectus paralysis here. To the right, both eyes are parallel. To the left, maximum deviation, up normal, down normal, up normal, again, down normal. Looking to the right, no deviation, no angle of deviation. and the deviation is variable, maximum when looking here in the direction of action of the paralyzed muscle, which is the lateral rectus. Here, patient with left lateral rectus paralysis, note the face turn to the left, face turn to the direction of action of the paralyzed muscle, left lateral rectus. Make the eyes look to the left, so the face turn is toward the left. We correct the face and then we look to the deviation. Looking to the right, no deviation at all. Looking to the left, the right eye can adduct, but the left eye, no abduction of the left eye, no movement of the left lateral rectus. So what are the choices here? The choices are, if you are having a left lateral rectus paralysis, there will be contracture of the medial rectus of the same eye, which is the direct antagonist. Also, excessive impulse trying to move this paralytic lateral rectus are going at the same time to the yoke muscle, which is the medial rectus of the other eye, making it overacting. Here, these strong muscles are colored by red, and here there will be secondary paresis of the contralateral lateral rectus. So the choice here is to recess the medial rectus of the same eye and to recess at the same time the medial rectus of the other eye, the contralateral medial rectus, that is the yoke muscle. So recess the direct antagonist and to recess the yoke muscle. And here is the post-operative after recessing medial rectus of the left eye and recessing the medial rectus of the right eye. The eye positions are corrected and also the face turn is corrected spontaneously. Here is another patient with 6th nerve palsy. In the primary position, she is well aligned eyes, no deviation in the primary position because it happened since short time before. If it is long standing, we could have more changes. Looking to the right, both eyes are parallel, but looking to the left, there is defective abduction of the left eye. Now, the trochlear nerve. Trochlear nerve or fourth cranial nerve palsy or superior oblique palsy. To revise the action of the superior oblique, depression of the eye in adduction and in torsion, and other tertiary action is helping with the inferior oblique in some abduction movement. So the main or the easier part of examination is to examine the depression of the eye in adduction, if it is full or not. There is limitation of depression of the eye in adduction. The eye is hypertropic in adduction, might be also in the primary position, and there is vertical diplopia. There is abnormal head position, and this is very important, and so you can pick cases of superior oblique palsy even when they are in the street. Head tilt and face turn toward the normal side and chin depression, and we'll see some of these patients. Here, the image of a faraway object is falling on the fovea and the fovea, but if the eye is hypertropic due to superior oblique palsy, the eye is turned up and the image will fall, instead of falling on the fovea, will fall on a point in the upper part of the retina. The upper part of the retina will understand any image falling on it as if coming from the opposite side, that is from lower down. By the upper retina we can see the floor and the stairs, and by the lower retina we can see the ceiling and the sky. Okay? Here is a case of left superior oblique palsy, head tilt to the normal side and face turn to the normal side and chin depression. This means that this eye is the one having the superior oblique palsy. we correct the head position first, and then we test the ocular movement. We have to let the patient abduct to put both eyes in adduction to look right and to look left. And here there is hypertrophy of the left eye in adduction as compared to the other eye. See the rim of sclera? How? In adduction of the left eye, left superior oblique palsy. But when looking to the left, the eyes are parallel when looking to the left. Compare this photo with this photo. There is hypertrophy of the left eye in adduction. Here, left superior oblique palsy, abnormal head posture, head tilt. Here it is evident, and face turn toward the normal side, and hypertrophy of the eye even in this adduction position. Question. Here, bilateral superior oblique palsy, we have here evident head tilt to the left, and the face is appearing as if there is shin depression. This one was having shin depression, but the head tilt to the left means that even if there is bilateral superior oblique palsy, this means that the right is more than the left. So we'll see this patient after looking right and left and putting the eyes in adduction here. Looking left, putting the right eye in adduction, there is inferior oblique overaction secondary to the superior oblique palsy. And looking to the right, making the left eye in adduction, there is hypertrophy of this left eye in adduction due to secondary inferior oblique overaction due to superior oblique palsy. In this patient, we had to study what changes are happening in this extraocular muscle. If we have superior oblique palsy, we have overaction of the direct antagonist, which is the inferior oblique muscle, which is one choice to operate. And the yoke muscle of the other eye, looking at the same direction as the superior oblique down and to the right, the inferior rectus, the yoke muscle, will have overaction and secondary paresis to superior rectus. So the first choice to operate is to weaken the inferior oblique of the same eye, and in this case in the two eyes, but unequal recession because they were not as equally overacting. The right eye was overacting more than the left eye, and there is graded recession of the inferior oblique, and we'll study the graded recession in muscle transposition surgery lecture. Here in the post-operative, the head tilt is corrected. The primary position, the eyes are parallel. They were parallel from the start, but the chin depression is corrected. But now, looking right and left is the document. Looking to the left, the right eye is no more hypertropic, and looking to the right, the left eye is no more hypertropic, and the hypertrophy is corrected and the patient is satisfied. Now, the last of all is the oculomotor nerve palsy. The oculomotor nerve palsy is accompanied by ptosis. Ptosis because the oculomotor is supplying as well the levator palpebrae superioris muscle in addition to the extraocular muscle he is supplying. So the ptosis is a cause of paralysis of the levator palpebrae superioris, and in this case the diplopia is masked. It is not no diplopia, but the diplopia is masked by the presence of ptosis. And if we elevate the upper eyelid manually, the patient will complain of the diplopia. There is limitation of movement of all extraocular muscles except the lateral rectus, which is supplied by the abducens nerve, and the superior oblique, which is supplied by the trochlear nerve. So the eye, after elevating the lid manually, will be seen abducted by the action of the intact lateral rectus and slightly depressed by the action of the intact superior oblique. There is some exophthalmos because of the loss of tone of the extraocular muscles, And then these two items, the dilated pupil and the lost accommodation, might be present and might not be present. This depends upon whether the parasympathetic fibers which are accompanying the oculomotor nerve are affected or not. If the parasympathetic fibers are affected, the ophthalmoplegia will be total and the pupils will be, the pupil in this eye will be dilated and accommodation also will be lost. The parasympathetic fibers are arising from the midbrain at the level of the superior colliculus, at the same level of the nucleus of the oculomotor nerve from the Edinger-Westphal nucleus. The parasympathetic fibers, preganglionic, are carried with the oculomotor nerve, and then when the oculomotor is divided into superior and inferior division, they go to the nerve of the inferior division of the oculomotor, then to the nerve of inferior oblique, and then go to the ciliary ganglion. We'll see this together. Now to see the diplopia. The diplopia here, if the object is falling on the fovea and on the fovea, and then in case of paralysis of the oculomotor, the major rectus is paralyzed. If the major rectus is paralyzed in this eye, right major rectus paralysis, this eye will be turned out, okay? And so the image will fall on the temporal half of the retina. If the image is falling on the temporal half of my right eye, this temporal half of the retina of my right eye will see the object as if coming from the left side. So paralysis of the right major rectus, what is the action of the right major rectus? Is to turn the eye to the left, so the false image will be to the left. Always the false image is present in the direction of action of the paralyzed muscle. Direction of action of the right major rectus is to look to the left, so the false image is to the left in front of the normal eye, and the normal image in the right in front of the paralytic eye with paralyzed muscle. So there is crossed diplopia in cases of major rectus paralysis. Now the total ophthalmoplegia, as I told you, might be affection only of the extraocular muscles supplied by the oculomotor. This is the external ophthalmoplegia. And if the intrinsic muscles supplied by the parasympathetic fibers going with the oculomotor, with the inferior division, with the nerve to inferior oblique, and then to the ciliary ganglion, and then entering the globe as postganglionic parasympathetic fibers to supply the sphincter pupillae and the ciliary muscle of accommodation. If this part also is affected, that is parasympathetic affection, this will lead to internal ophthalmoplegia. If both together, this is total ophthalmoplegia of the oculomotor nerve. This depends upon the clinical picture that we will see. This is a patient with only external ophthalmoplegia. Ptosis, when we elevate the lid manually, the eye is abducted, lateral rectus, slightly down by the superior oblique. We look to the pupil, easy to look to the pupil, then to examine the accommodation. The pupil is not dilated, so no parasympathetic affection. So here there is only external ophthalmoplegia. Here in this child, having partial ptosis, the eye abducted and slightly depressed due to oculomotor paralysis. And here we studied the changes that occurred. Paresis of the major rectus is accompanied by contracture of the direct antagonist, which is the lateral rectus of the same eye, and that is why the eye is abducted here. And the paresis of the major rectus here is accompanied by overaction of the yoke muscle, which is the lateral rectus of the other eye. So when we decide to operate, first, we have to recess the direct antagonist, which is the lateral rectus of the same eye. And if there is some action, not complete paralysis of the major rectus, we can resect this muscle. Like in this case, we reset the lateral rectus by recession or weakening procedure, and we resected the major rectus or strengthening procedure of this major rectus. And here is the post-operative. This is still the pre-operative. The post-operative is here. Both eyes are parallel. No exotropy in this eye. Full abduction after resecting the paralytic major rectus. The action is beginning, and both eyes are parallel. But is the only thing that is remaining from the total ophthalmoplegia is the dilated pupil due to affection of the sphincter pupillae and the cerebral muscle of accommodation leading to defective accommodation in this eye. But this could be overcome by blurring of the image of the in front of the sunlight. He is wearing sunglasses when he is out because we can do nothing for this dilated pupil. The operation or the curing of the oculomotor nerve palsy is to cure the extraocular muscles that are affected. We recessed the lateral rectus, the strong, the direct antagonist, and we resected the major rectus, which is the affected muscle, which was only paralytic muscle. Now we go to the treatment of paralytic squint. It's completely different than the treatment of comitant squint. First of all, we have to treat the cause, because the cause here might be something serious, might be something intracranial. As we said before, it might be tumor. During the period of treatment, we have to overcome the diplopia, because the diplopia is annoying to the patient. So we can get rid of diplopia either by occlusion, which can be alternating in each eye one day. We choose not like occlusion therapy for amblyopia in comitant squint. This is completely different. Occlusion here is to get rid of diplopia. We can occlude one day the right eye, one day the left eye, so not to get any complications. Or if the deviation is not big, we can use brace in the glasses. The brace here is a relieving brace that is placed with the apex toward the deviation. This is contrary, different than what is known as the exercising brace. It is the contrary. Here, the apex toward the deviation to just bring the image into the fold. Surgery, not before 6 months. I give you one example of this patient having bilateral 6-nerve palsy. She presented with this condition, and some doctor has operated her left rectus. I don't know why, for investigating her. The first thing we had to do was to do MRI to investigate the brain, and she was having a brain tumor which is in the pons and the midbrain extending to the pons, and it was inoperable because the primary lesion and the nuclei, we had to investigate the pons. That we asked the area to be investigated by MRI to be concentrating, but it was extending from pons to brain and inoperable, and she died within 2 months. What type of surgery we can do? In cases of paralytic squint, we recess the antagonistic muscle, which is strong. Example, if in case of lateral rectus paresis, we recess the major rectus. And also we can resect the paralytic muscle if there is some action. And if the muscle is completely paralyzed, we can do muscle transposition. And thank you so much for your kind attention. Thank you.